Okay, good afternoon, everybody. This is the April 17th regular meeting of the Pitkin County Board of Health. Thank you all for being here. Right off the bat, I just want to welcome Sam Rose, who's our new member as the appointee from the city. So welcome.
Thank you.
Welcome to the Board of Health. You've got a good group to join here.
Yeah.
You were the lucky one. I'm glad it's you. All those things.
Yeah.
I'm so glad you're here.
Appreciate that. Very much so. Thank you.
Yeah, good. Let's see, we need a roll call. Do we need a roll call or do we just say, we have a quorum? We know we have a quorum.
Can you see who we have?
Oh,
online?
and Cecily, are you our designee from Snowmass?
Yes. She's the
The alternate. Well, come on down. You can grab a seat here if you want. Great. Susan, how are you? Welcome. So
Good to be here.
Liz Stark is here, Dr. Tom Curtis here, Sam Rose is here, Linda Vieira is here, Susan Merle's here, and Cecily D'Angelo's here. Well, that sounds like a roll call to me. Good
Yes.
enough. We've got a quorum. We're going to keep going.
And then online we have Jordana.
Oh, who's online?
Jordana.
Jordana.
and
Oh,
the
her.
other
Jordana. Oh, you're here.
side.
Welcome. Just chime in if I neglect to do something. Okay, regarding the agenda today, just a quick perusal. Are there any changes or additions we want to make to this? Larissa,
No changes.
okay, sounds good. Let's see, I would need a motion to approve the previous minutes
So
unless,
moved.
okay, I've got a motion.
Second it.
And a second from,
Linda.
oh, it's Linda. Okay, I wouldn't, Susan or Linda. Okay, all in favor? Aye. We're going to keep moving here. We're going to open this to public comment. If there's anyone online who'd like to make a comment, I believe it's *9 to raise your hand or just unmute and yell at us. And if you'd like to make a comment, I can't really tell who's there, but and if there's no one in the room that I don't recognize, so I'm going to assume nobody wants to get up and make a public comment. I don't see anybody raising their hand. So we're just going to bring it back. I'm going to close the public comment. If somebody does come along who really wants to tell us something, I don't mind opening it up again if it's one person or something. Up first, board elections. I'm going to hand this over to Larissa.
All right, it is time again for board elections. Last time we did this was April of last year. So at our second quarterly meeting, we always elect chair and vice chair positions. And so what we will do is open up the floor first for nominations for chair and then vote. And then we'll do the same process for vice chair. So that being said, floor is open for nominations.
Oh,
for
I don't
chair.
hear any nominations. We're going to have to start this over.
Nominate Greg Pushman.
I second it.
Come on, anybody else?
That sounds good to me.
You love it, girl.
I actually have to say I enjoy it and it's okay. This one's easy. People who want to sign Tori's thank you note, send that along if you don't mind. So do I need to give a speech or anything? No, I can just call the question.
You're welcome to. Are there any other nominations?
Are there
for
any other
chair?
nominations? Come on. Okay.
All right.
I just want
And then Larissa, just for voting members, we can have one voting member each from each of the municipalities. So Greg will vote from
for myself.
for Pitkin. Looks like Susan should vote for Snowmass, and then Sam will vote from Aspen. And then because Krista is not present,
We can just
Barry.
elect her an abstention.
Yeah, Barry, Liz, Linda, and Tom can all be voting members today.
Okay.
Great. Thank you. Thanks for that, Jordana. You're amazing how lucid you are on all those, various substances.
Just Tylenol and Advil at this point.
Okay, I'm gonna call the question. I don't feel a need to make a speech. You've elected once again a deeply disturbed and disqualified chair, but we seem to muddle through. All in favor?
Okay.
Aye. Okay, now I want to open this or Larissa, you should open this for,
Yes, I'd like to open the floor for nominations for vice chair.
I'll nominate Krista.
I'll second it.
Second from Susan. further discussion? See how I open it to discussion? Because she's not here, we,
Really?
all in
And
favor?
And
Oh,
she
sorry.
did, just to chime in, that she did share that she was hoping to be nominated to serve again as vice chair. So this is aligned with what she is eager to continue serving.
I do appreciate that, although I always say I'm always suspicious of people who are eager to serve. All in favor?
Aye.
Aye. Did we have a motion in a second? We did, didn't we?
Yeah.
I second
Did
it.
we?
Yeah.
Okay. Just wanna make sure. All right. That was, thank you all. That was easy and painless, and I appreciate that. I really do. Okay, Kurt, I think you're up next. We're going to talk about emergency preparedness and response presentation, and we've got Chris and Chris Breitbach. Somewhere,
Chris is not
not with us today.
here.
All right.
All right, am I on here? Yep.
Yep.
So, good afternoon, everyone. Kurt Dahl, Pitkin County Environmental Health Manager. You get me today. Carlin Porter, who is our emergency preparedness coordinator, is on vacation. And Chris Beitbrock, who's the county emergency manager, who is also going to present, is traveling back from leave today. And so he's not available. So they had some slides put together that I've gone through, and I'm going to walk you through these around emergency preparedness. What we're going to talk today is county emergency preparedness, the emergency management system, a little bit about emergency response, how public health fits into that. And then our Public Health Emergency Preparedness Program, or PHEP is what we call it, is the acronym. And that is a grant-funded program that's federal pass-through. So
Is that the same as the LAPC?
no, it's not. LEPC is not funded, but is a requirement from FEMA for counties. LEPC stands for Local Emergency Planning Committee, right? That is required through the Superfund reenactment, SARA Title III, and is around the Emergency Preparedness and Community Right to Know Act, which basically requires anybody who stores hazardous chemicals to report that to the PA. That goes back down to the state health department and then local planning committees, which is the LEPC. That's different. That is something that I think the reason Dr. Kurt asks that is I happen to be the chair of that, but that is not a specific role to public health. I just happen to be in that role. So does that make sense? The other thing I wanted to just mention is this presentation is based on what we know right now. I want to acknowledge right now that we may have a little uncertainty with what's going on with the federal changes. And I've been in discussions even this morning. We had the CALFO, which is the Colorado Association of Local Public Health Officials. There were discussions around public health funding, including the PHEP funding, and some uncertainty around the funding and then how that might affect things like scope of work. But for now, we're going to run with this presentation. Just recognize this could be changing over time.
Lately, it's in changing one day and then changing back the next. So.
And yeah, so take everything with a grain of salt. And at the end of the day, it likely doesn't change a lot of how we respond. It's more reporting agencies and funding are the big things that come from the feds. So, so when we talk about an incident, they begin locally, and as somebody who's local, there's a saying that we like to use that all events are local. Right, they all start at a local level, and then you may end working with resources that come from up as the event grows. So, when you have an event, and if you think of fire, right, that's an easy one where, you have a fire, somebody calls it in, the fire department is dispatched, they go out, they assess the fire, determine if they need any assistance, and if they don't, they put the fire out. A lot of ways public health is the same way. We will have disease reports. We have a system that we work with that if we get a disease report, we'll investigate that disease. If we don't need any assistance, we do the investigation. If there are no other cases, we close it. And then if you end up with additional cases or you need support beyond what you have for resources, you then start calling in other folks. And it's the same with the county emergency preparedness. So you start at your agency, and then you have regional, and then you can go to state, and then finally federal. So as the size and scope increase, there becomes a need for an incident management team. And we all train, anybody who does emergency response, whether that's your public safety folks, your government agencies, non-government agencies, we all train in what's called an incident command system. And that basic training outlines how you manage an incident and the different roles that you have. In that role, there's what's called an incident management team. And those are the folks that are directly at the scene responding to the emergency. And they're the ones that are, the hoses on the fire or investigating or working to actively control the incident. And then you have other agencies that are support. So as you have an incident management team, that can grow with resources from other places. When it's local and it's regional, you have those resources. When you need assistance, further assistance, then you call the state, and then they can bring in resources. And then if the state needs additional resources, they can go to the feds. And you have to go through that chain. I can't just call the White House and tell them, hey, we need help, right? And neither can others. So the important thing is when you start out locally and regionally, those resources typically are staffing and people. As you move up the ladder to the state and federal agencies, that's really funding, maybe equipment, sometimes people, depending on the situation, but it becomes less about people and more about information and funding and maybe equipment pieces. So, and that's a really important thing, so that locally, if we need additional resources in terms of people, a lot of times will be funding that will come from the feds. And if you think about when we did COVID, right, we ended up receiving federal funding that helped us to hire staff as part of that to expand our team locally. And the feds were actually passing either funding or information and research. The CDC was giving us information on like quarantine and isolation. So you have an incident management team that's controlling everything locally, and that's at the bottom of the picture here. And you can see where that talks about the difference between command and coordination. So again, command is we're actively addressing whatever the emergency is. Coordination is in all support, mostly support. So with the IMT, then you have experts that are working on that. And then just above that, you see local EOCs. And I want to point that out. That's an emergency operations center. And what that is that again is a local emergency operations center is a team that supports the incident command. So they're not on the scene helping to address the issue. They're somewhere else in a separate location with communications supporting that team with things like resources. So again, if we had a flood and I need a grader, right, that EOC, there are teams within that EOC that are then supporting to get the grader, whether they have local or regional folks that they can help reach out to, or they go to the state to ask the state for that help. The reason I bring those things up is when we think about incidents and we think about public health, there are two places where we get involved in the response to an incident. And one is as a source matter expert in the incident management team, right? So again, you think of COVID, it was a disease that was our expertise. We served as part of the initial incident management team when we stood up the original response. And then because of that was so long-term, we ended up having to hand that off because that emergency response with that incident management team couldn't go
Pitkin
forever.
County epidemiologist, what's the,
Eventually
is
we
there an
did.
intermesh role or, explain to me.
Right. So when COVID first hit, we stood up the incident management team because we had a staff of, Jordana, correct me, 5.5 at the time, right? So we didn't have enough people to respond. So we utilized that team, which were across other agencies, to help us with that initial response. And then or Dr. Kurt, what you're referring to is eventually, because of the length of that, we had to then step the incident management team down and let public health take over, which were our epidemiologists and the rest of the team that we hired. That took over and then ran with that for the rest of the time period.
And
So
also ask them, each fire department usually has a fire marshal, which functions, in inspecting buildings for sprinkler systems and that kind of thing. Since we have a county and the Aspen Fire Department is separate totally from that. Is there a fire marshal here that does inspections like as a new hotel, Molly's and that kind of things?
Absolutely. Yeah, we have a fire marshal, we have a deputy fire marshal, and we just hired a new fire inspector as well.
Right. And that's part of the
Just wanted to
public.
get that on the record.
And each district has, so City of Aspen Fire District, there's Roaring Fork Fire District that includes Snowmass. They all have fire marshals that are coordinated within the city and county, same with Basalt, to do those inspections. In terms of an emergency response, we have interagencies that are all playing together in that response. So across the board, you may have things like fire and police and emergency services, Aspen Ambulance District, working together to address that incident. So back to when we talk about an actual incident. So Pitkin County Public Health and other public health agencies play two roles a lot of times when we're talking about emergency response. We may be helping out at the scene, especially like with this disease investigation. That is ours. That lives within our department. And we will be at the scene as public health experts and communicable disease experts. That's part of the incident management team. The other place that we get involved with emergency response are these emergency operation centers. And in our designation, we're called ESF8, which stands for Emergency Support Function. The number 8 just refers to health and medical. There are 15 total that are all different types. So there's transportation, there's security, there's recovery. There are a number of different ones. We can get you the list if you need. More important that each of those has a job to do, and that's supporting those individual pieces. The transportation is looking at transportation for, if we have an event, we stand up the incident management team here locally for things like X Games. Transportation becomes a big point. The EOC, a part of that transportation, is then looking at all the transportation resources that the incident management team needs to help with the transportation of all the folks coming in and out of Aspen, as an example. So again, it's a little confusing, and this was part of going through COVID, trying to understand where our roles were, because previous to COVID, we were working a lot and doing a lot of training around EOCs. But the recognition now is we have roles in both places because we have expertise. We may be called in to actually help with the response itself versus just in a support role. Does that make sense?
Hey, Kurt, question.
Yep.
So say federal funding goes away, the state is overwhelmed. It comes back to the local EOC, and I see a little sidebar that says local to local, mutual aid, private sector, NGO assistance, all that. We probably ought to just talk a little bit about that, because already we're seeing with the loss of federal aid, we're seeing staff coming to us saying, well, we lost this federal grant. Can the county pick up the backfill? And we've pretty much been able to handle that at the outset, but can't anticipate that going on forever. We're if something comes down the line, we're going to need to ask for help. And so I'm my current thought is I want to make sure that staff and the county and the other entities know that we do have an incredible community here that has stepped up many, many times to help, and that we may have to rely on that at some point if something happens. Maybe if nothing really big happens, we still may rely on that, because it seems as if we're back to, figuring things out for ourselves, at least on, not necessarily with public health right now, but with other things I'm seeing in the county. So I don't know if there's anything else to say about that, but it's been on my mind a lot. If the feds don't show up, we're lucky in that we're a county that actually has some resources and can backfill or fill the gap to an extent, maybe more than other communities in the state.
I think the only thing that I can say there is it's on my mind as well is how do we think about resources that we have? I think for public health, COVID has taught us a lot about response and what our needs are. Carly Sinst, who's our epidemiologist, that position came out of COVID and has been a huge benefit to our department in terms of preparation. And it's something I'll talk about in a little bit, as well as she works in conjunction with Carlin in emergency preparedness. And I think that comes back to this uncertainty that I started with at the beginning of the conversation. We don't know what we don't know right now. But it is a concern of if we have a response, what is going to happen? But we don't know. It's kind of that black box right now of, until we know, we may not know.
We also have the Colorado National Guard, as you know, after 9/11. Each state was given about 30 full-time officers in the National Guard of each state. And I've seen their van, their RV out at the X Games.
Right.
It's there, and it's more of a communications base for every major event that you have where a disaster could occur, and they coordinate as a kind of a dispatch center.
Yeah, thank you. And that's one of the benefits of things like X Games is it actually allows them an opportunity to come and practice. in a
Practice,
safe-
exactly.
I guess the point I was making is that what I'm hoping is that when things like this come up, we need to be one, innovative and look around to see what other nonprofits may be doing things, or, you know, what's happening in the community, because we may have resources we hadn't contemplated when we're looking to the feds for the money previously.
Right, right. The optimist in me does hope that, I sit on the NACHO, National Association and City and County Health Officials, Environmental Health Board. And we are Environmental Health Work Group. And we had a presentation from an individual who has been working with us from the CDC. And while there was a little bit of a gut punch of listening to him talk about the changes going on and some of the divisions going away, one of the things that he was clear, though, was some of this is about realignment. So some of the divisions or some of the folks that were working under him in his environmental health division, really what's happening to them is, yes, they were let go in that division, but they're being moved to another division. They're not going to be under the CDC, but they will still be there, just functioning in a different department. So I'm hopeful some of that realignment, everybody's not necessarily going to go away, because that was my initial reaction to some of the reports, is that departments are just getting cut and going away. Sounds like there's some realignment going on. And so hopefully maybe it's not quite as bad as we think. It's just, you know, we'll have some cuts and it's going to hurt, but may not be that bad.
Great, thanks for that. Any other questions on this, or are we?
Yeah,
done?
we can go to the next slide.
Great.
So in talking about the emergency management, so that's talking about the actual incident. And the role of the emergency manager for the county is to coordinate amongst agencies. You know, Dr. Kurtigan was talking about the City of Aspen fire. So there are multiple agencies that respond again to a potential incident. And so he's coordinating amongst all of these agencies. He is or in this case, Chris is the contact for emergency preparedness folks at the state level, regional level, and local level. And he then is responsible for preparing the emergency operations plan for the county, which looks at the different hazards we have and how we're going to respond. And the all hazard plan as well, which is a plan that actually identifies the various potential for hazards that we have within the region, and then starts to outline how we might think about responding to them. And then we have to maintain those and train with those. And the important piece that this slide that Chris had for me that I wanted to talk through was the preparedness cycle that he has up here. And essentially, really what I want you all to gain from that is it's a cycle. It never ends. So you work through, you organize, you train, you exercise, then you debrief, which is a really important in the exercise. What went right? What went wrong? And then you make another plan and you continue to go through that cycle every time. We have information that updates. We have training that updates. We, science updates what we understand. We have resource differences that all continue. So as we think about in preparation for events, we're in this continual cycle of looking at plans, updating plans, training on plans, debriefing them, and then going back through the cycle again every so often. The all hazard plan gets updated every 5 years. We just went through that as a county last year and it's been adopted. So Chris will start that process again in a little bit. So again, those plans outline how we're going to respond and talk about the different agency roles in doing a response. The other thing I told Chris, I wanted to make sure everybody has heard, is promoting the Pitkin Alert. No, I think most of you've probably heard about that, but if you aren't signed up for Pitkin Alert, again, that's an information system for the community that if we have an emergency, that will give you information on that. It also, we utilize that for information for things like smoke and other health related incidents that might happen if we had like a wildfire. So he just said that anytime he gets an opportunity, he's putting that plug in. So if you haven't signed up for it, it's pitkinalert.org, and you can utilize that. Any questions on that? So again, this is the county level piece and a little bit about how we, Pitkin County Public Health, sit in that piece. So you want to go to the next slide, please? So just as an example, because public health is, at least from what I understand from Chris, unique, not unique, but there are only a few other agencies that end up responding to or helping out in a response to so many different types of events. Again, we've talked about disease outbreaks. That is something that COVID is an excellent example, so that shouldn't come as a surprise. Natural disasters, we have wildfires, we have smoke and water quality issues that we help with or work with community on. Flooding, again, we have health concerns around flooding and mold once the flood has occurred. The potential issues with hazmat spills, again, that could be associated even with floods and household chemicals. Human-caused disasters, you know, the example that was given here was a diesel spill. Again, we have a concern around how that might impact human health, and so that's why we get involved eventually. And then in any type of event, you may have an evacuation, and so there are a couple of things that public health will get involved with evacuations. One is the mental health side of, and coordinating mental health services is an important part of evacuation. The other is evacuation center sanitation, which is we have a plan called an EH surety plan or environmental health surety plan, and that looks at health in evacuation centers. So things like, you know, sanitation standards, are there bathrooms, is there water, running water, is it coming from a potable source? You know, do you have minimum square footage for individuals or families to prevent the spread of disease? So it's a plan that we have that we can outline going through and doing literally an inspection to ensure that there are different aspects to prevent disease spread. You know, and it comes down to a number of different things we think about. Animals is another. If you have animals at an evacuation center, are you providing them enough space? Do they have a place to use the bathroom? Those sorts of things. So there are a number of different areas where we might get involved if we had an incident specific to the county and public health. Next one, please. All right. So the next couple of slides are pretty busy. Please don't try to read all of them. That's not the intent here. But public health emergency preparedness, again, that's a grant-funded program. Carlin Porter's our program administrator, and she works with the state health department, and this funding comes through the CDC and requires us to do a number of things in preparation for responding to an event and including responding to an event. And again, if you notice, it's very similar to what Chris's role as the emergency manager, and it's around planning, training, doing exercises. We specifically you call out regional coordination. And then the other thing that is part of our FEP scope of work is taking leadership with the emergency support function, or ESF8, that I talked about with the Emergency Operations Center. So we have requirements within that grant that we take the lead so that we're coordinating if we're in the support mode for an incident management team. Next slide.
Hey, can I ask a quick
Yep,
question while we're
absolutely.
on there? I was just trying to load the ReachWell app, but we need a code, and the code wasn't legible on the screen.
Oh,
So how do we actually get that? You happen to know?
I will have to
Figure it out.
check.
The same question.
Okay, right.
Reach
Kurt,
well. Oh,
you should be able to download the app, Greg, independently, and
Right.
then you can just hit the add button, and then search by name and type in Pitkin, and Pitkin County alerts will pop up.
Oh, done. Okay, thank you.
thanks, Jordana.
I have a question, Sam. What's the closest hazmat team to Aspen?
Closest hazmat
I know that if you don't.
is in Grand Junction.
Grand Junction,
Yeah,
State Patrol in Grand Junction if we have a hazmat incident.
we're trained on hazmat too, but hazmat team, Grand Junction.
Right. Sorry, I forgot you volunteer for the fire department.
Yeah,
Phil? Yeah,
yeah.
okay. I was saying my role is LEPC chair.
Yeah. No,
Okay,
you're
sorry.
definitely the resident expert on hazmat. Not me.
I don't know about that, but yeah.
Higher
There was
credentials.
a hat that I wore a long time ago. Okay, back to this. So again, around that planning, please don't be overwhelmed by the slide. Please don't think you need to read everything on this slide. The intent here is just, there are a number of plans that we're responsible for and updating on various schedules. As part of the federal scope of work, they actually require us to update some of these plans on a regular basis. And then there are other plans that, as we went through COVID, we've chosen to update ourselves. So when you're thinking of a plan, those things are really, when we're involved as subject matter experts with, again, that incident management team responding to that incident, those are things that are really we're talking about with plans. Those plans inform us on how we're going to address whatever the issue is. In this case, we have things like if we have to do mass prophylaxis, point of distribution, we have plans for how to do that, where we're going to locate that. We also have, again, I already talked about the environmental health surety plan if we need to do inspections of evacuation centers. We all know our favorite quarantine and isolation plans. We have, plans around what to do with quarantine and isolation. These plans are written generally because a lot of times, especially if we're dealing with disease agents, it's going to be pretty specific to that disease agent and we have to fill in. But we do the best we can to fill in as much information as we have, leaving open what we can to then specifically address it. So if we have, right now we're working on measles prep. We've actually pulled out and specifically written out, a measles response plan because measles is a little different. And again, it's specific to that, but we utilize these plans and actually develop them. So it also has some of our ESF 8 information in here, as well as we have some memorandums of understanding or MOUs with pharmaceutical distribution, and then volunteer work as well. That's what the Rocky Mountain Medical Reserve Corps is. So again, a lot of work, and that's kind of the important piece here, is that there's a lot of prep that is going on behind the scenes. Next slide, please. So this is an example of a plan, and again, you can see where it's written somewhat generally. This is Carlin pulled out the responder and safety plan. So this is really looking at making sure when you are in a response that you are having adequate PPP for your responders, that they're adequately trained, and you're outlining those pieces as you work through that. And again, this is specific to responding to that scene as part of that incident management team. You're part of what we call operations. And again, it's to protect the health of the responder. So that's just an example of one of the plans.
I have a question about, for instance, an evacuation plan,
Mhm.
because I think people often want to know, like, specifically, what should I do? And
Mhm.
and I think that's different depending on what the threat is and and I guess that's part of the communication, but I think that's kind of a tough spot because I think people are looking for specifics, and when they don't get specifics, then they kind of assume that there is no plan. So I guess that's kind of what feedback I've gotten a little bit, or questions, I guess people want to know.
People, yeah, right. And I think people want to know as specific as they can, but I think you're exactly correct. It's all situational. And I think the best thing, again, the evacuation plan isn't public health, right? And I think that's one of the important pieces when we talk about, these different plans and where our roles are.
Yeah.
Do we play a part in evacuation? Yeah, and we're supporting that. That really is more in the emergency services and their planning, but you're right. There's only so much information you can give because it's very specific on
Even
where's the
anyways,
location of the incident,
yeah.
where are we telling people to go? Sometimes it's sheltering in place. It's not, we don't want you to
Right.
evacuate. We want you to stay in your house. So those are all situations that, yeah, we want the information, but again, it's got to be specific to the scenario.
Yeah.
And
I guess
Kurt,
sorry.
if I could just add there, because of that, trying to respond to those citizen concerns, I think just as Chris had us share the Reachwell app and the Pitkin Alert app, knowing that there are kind of these general plans, but the more specific plans will depend on the incident, letting citizens know that they are what they can do to be prepared. before an incident involves making sure that they're signed up for all of those communication notices, and then also more of that piece of personal preparedness of having a go bag or things like that, because the actual response in will depend on the emergency.
Right. And the Reach Well app, is it also accessible at the same place as the Pitkin Alert app? How do you get the Reach Well app?
I need to check with Chris on that. I didn't realize that was a live link when I copied that into the slide. So I have much more familiarity with the Pick and Alert app
Yeah.
than the Reach Well. So I will check with him and I can get back with you all on that aspect. So I did want to add on to Jordana's piece around the importance of being connected with communications. As she said, that's part of the reason we have Pick and Alert is so that we can inform people when we do have that. I think the other thing and I heard this a lot from the Valerie McDonald, who was previous to Chris as the emergency manager. One of the things that she always wanted us to impress on everybody is to make sure that you understand, and this is something for the community, that the cavalry isn't necessarily coming, right? When we have an emergency, there's an aspect of you're responsible for yourself. And as part of the LEPC chair, one of the important things that we kept talking about after the tragedies in Lahaina was that people were waiting around for folks to tell them either what to do or thinking that the cavalry was going to come get them in evacuations. That's really, we don't have those type of resources. And I think we see that on TV, and I think a lot of people expect that. We have search and rescue goes out and rescues an individual off, Maroon Bells, but that's a one-off thing in a time period where we can expend those resources. It's really important that folks understand that if you think you need to go. Don't wait for somebody to tell you. Right. And that seems to be a communication piece that a lot of places are trying to reinforce now. And when you have that, you need to have that go bag. You need to be ready to go, and don't wait for somebody to tell you. If you think it's time, go. Be safe. So.
And is that also a piece of if for some reason our alert system doesn't work properly, is that also like a part of the communication? Because I guess I don't fully understand what was going on in Los Angeles, but it sounded like some of the pings weren't pinging correctly to different neighborhoods for people to evacuate.
Yeah, and I don't specifically know about that, but honestly, with technology, it wouldn't surprise me. And again, I think that is that aspect of, again, be responsible for yourself. And if you think you're uncomfortable, go. There's nothing wrong with leaving. Don't think you need to wait it out, or don't expect that somebody's going to come get you to pull you out. So, but it wouldn't surprise me if they had those technological issues, and that unfortunately, it's perfect as we want the system to be. We're only, we've got to take that initiative ourselves too.
Okay, what's next?
Time check here. Next slide, please. So again, just coming back to all these pieces with the FEP. So we have plans, we have training, public health. We have a number of pieces of training that were required. ICS, again, that's Incident Command System. That is the management structure training that we talked about with response to emergencies that, again, all responding agencies go through, county employees, emergency services, public health. We have a number of them that we're required to take. Carlin manages that, as well as there's a intro to public health emergencies that is on what CoTrain is a state system around public health training. It has a number of them, including this introduction to public health emergency response. So as we have new staff come on, the managers are ensuring that staff are taking the training courses that they need. We just literally went through this with the managers last month. So next slide, please. Again, a little more on the exercise piece. So I have training and we have exercises. Carlin and Carly just went to a tabletop exercise on measles. And again, for those not familiar, tabletop is an exercise where you have a situation, you're all sitting at the table, you discuss what your response would be, and then you debrief. And it's a very effective and relatively easy way to pull people together to talk through a response without having to get equipment and all these other pieces together. having participated in a few of them, it's a really great piece, and especially that debrief on, you know, if you have experts at the table, they can debrief you on, did you think about doing this? Did you think about doing that? So because measles and the outbreak that's going on in the southwest part of the country, and now with Colorado having a couple of cases, they had a measles tabletop. Carlin went. Last year we held a rabies tabletop. We've had a few other ones, and then Carlin has also been trained to set up and create tabletop exercises. And so that's one of the tools that we use when we talk about exercising our capacity. So next. Right. So, and then the last piece to talk about, so when we talked about we were responding, that first piece with regional and state. So we work closely again with our regional partners, and some of that has to do with just the nature of the Roaring Fork Valley with Eagle and Garfield County being so close, but it's true across the state. You do work a lot with your other regional partners. Lauren is our regional epi. She's actually going to do our epi update today since Carly's out. And we meet with her monthly to talk through the different disease communications coming from the state or investigations, questions. We are also coordinating with other field managers, and then Carlin is also participating in the Northwest Regional Healthcare Coalition, which is our Northwest region part of our state, which are, again, public health, hospital, emergency services, behavioral health, all getting together to talk around emergency response and how to coordinate emergency responses. So those are regional pieces that, again, we're doing as part of the deliverable for the FEP grant. I think that was technically the last slide.
Great. And questions? Questions for Kurt or anyone else? I think we're ahead of schedule, which I always like.
Give me one more sec.
ahead.
Let me
Yeah, go
Let me
ahead.
close it with this. So just to come back, because, you know, again, doing multiple persons presentations. So, you know, the county, the health department, we're part of a larger team of people that respond to emergencies, right? We have a couple of places where we end up getting involved in emergency response. One is either the direct role, the other could be supporting. And the other thing that I failed to mention is sometimes it could be both, right? And it's a small rural agency. That's one of the biggest challenges. I know Liz was really involved with the COVID response, and that was one of the challenges we had in COVID is we had all of our experts on the incident management team, but we also needed to be in our support function role. And one of the things that we're still trying to sort through is understanding how do we as a department, when our bench depth is only so much, how do we address dealing with situations where we have to be in both places? So again, it's a complicated piece, but COVID had a lot of really great lessons that we came out of that. And then the other important piece that out of this is there's a lot of work that goes involved. We see the response, but the vast majority of the work isn't the response. It's all the preparation, the training, the planning that goes into that aspect. And I you know, put it into Google to see if there was a number, and unfortunately there's not. It all depends on the situation, but there's a consensus that you spend much more amount of time preparing for the response than you actually do in the response in most cases. So, and that's an important piece, and I think we have a number of examples where that's true. We have MPOX, where we, to my knowledge, never had a local case, but we spent a lot of time preparing in case we did last year. Right now, we have hundreds of hours in staff time already working on measles and measles plans. We don't have a local case yet. It's true for a lot of things. So I think those are the important pieces that Chris and Carlin wanted to make sure that you all knew. So thank you.
Yeah, thank you. Thanks for underlining that. Yeah, go ahead. Did you want to say something? It's true. It's like, and the better organized you are, the less the public knows sees anything, right?
Right.
So,
Right.
It's a thankless job.
Preparedness and prevention are unseen, and
Right.
it's a very difficult thing to get the public to understand sometimes.
It's like fire preparedness too.
Yep.
Throwing one to
It
sand.
absolutely
It's
is.
like, yeah,
Yeah.
if we're really prepared for fire, it won't be so bad, right? Okay, I think Lauren is here and we're ready. We're 20 minutes ahead of schedule. I'm sorry Carly's not here, but I understand Lauren is our visiting celebrity epidemiologist. So Lauren, welcome and go right ahead, launch in. Thanks for being here.
Yeah, thank you guys for having me today. So my name's Lauren Duvall. I am the field epidemiologist at the Colorado Department of Public Health and Environment that's assigned to Pitkin County. My job here at CDPHE is really to provide regional support to counties on the Western Slope in the Northwest region and the West region on all things communicable disease. So happy to be here while Carly is out. Today, I'm going to be giving a update on viral respiratory diseases. So we're going to start briefly with an update on kind of COVID, RSV, and flu, and then we'll move into probably what is on everyone's mind, which is what's going on with measles in the United States and within Colorado, and what our response looks like. So to start off, we are pretty much at the end of our viral respiratory season. So CDC announced last week that was their last federal update for this respiratory season. And so we are continuing to see the amount of acute respiratory illness to decrease and really remain at a low level. Seasonal influenza activity continues to decline, and COVID and RSV activity are declining nationally to low levels. This can also be seen in the state of Colorado. I have a screenshot of our viral respiratory diseases dashboard. And you can see this was updated yesterday. We are seeing COVID, influenza, and RSV at pretty much low levels. I do want to just note that while we are at the end of our viral respiratory season, COVID continues to not follow the same cycle as influenza and RSV. So you can see on kind of our screenshot here, we did see a peak of COVID activity again last summer, in the middle of the summer. So while CDC is kind of stopping their national updates, we will be updating our viral respiratory diseases dashboard on a weekly basis, even in the summer, so that we're able to track kind of our trends across the state of Colorado. I've heard from some of my Pitkin County public health counterparts that you guys are always interested in our wastewater surveillance data. So while we are seeing continue to see detections of RSV in our wastewater, we do expect that to continue to decrease in the coming week or two. And so this data is always about a week behind in terms of the trends that we're able to report out on. So we continue to expect this to decline into next week as we see lower hospital admissions, lower hospitalization rates, and really are getting to pretty much low level across the board on all of the detections that we monitor for viral respiratory. So we can go, that's all my updates on COVID, flu, and RSV, but always able to take questions. I guess I'll pause before moving on to measles. Is there any questions on people's mind right now about COVID, flu, or RSV?
I just had a quick question, but I'll entertain others. How many different, is it disease vectors or injury accident vectors do you actually track?
Or I think right now we're at, I don't want to overspeak, but we're looking at hospital admission rates. We're looking at weekly hospital admissions, ED visits, and also our some of our laboratory testing that is reportable to the state of Colorado. We are tracking that along with our wastewater surveillance data. And those are the key factors that we consider when we're talking about respiratory illness. But we also have some hospitals that participate in more sentinel surveillance, especially in the Denver metro, that we're tracking even more factors with those participating hospital systems.
Great, thank you. Any other questions from the board or the?
I think you're asking about a list of reportable diseases. Every state, including Colorado, has a list of reportable diseases that include your STIs plus.
Yes, and I can send a list of that. We have I think now we're up to over 85 reportable diseases in the state of Colorado, ranging from respiratory diseases to animal bites to outbreaks of any disease, and much more than that. I can send a list for everyone to review. That is written by our state board of health and incorporated into our Colorado code of regulation statewide. I'll send a link to that after my presentation.
Great, thank you. All right, let's keep going.
Okay, so this is what has been in the news lately. So kind of just updates on measles in the United States. So far in the state in the year of 2025, there's been a total of 712 cases of measles in the United States, reported by over 25 different jurisdictions. And this was updated as of April 10th by CDC. And so this number probably has increased. Currently, we're getting updates. They are going to start making updates at noon on Thursdays, and then so we don't have updates for this week posted yet on CDC's website. So 712 cases. This is, I want to emphasize, an unprecedented amount of cases in the United States. We're beginning to see cases in Texas, where we have seen a large statewide outbreak and community-wide spread, as well as in New Mexico. This has since been detected in several other states across the entire United States. I want to note that 97% of these cases are in either unvaccinated or unknown immunization status. And so this is largely in our unvaccinated population in the United States. Out of these cases, there have been 7 outbreaks reported. And this is what accounts for the majority of these cases. You can go to the next slide. When we're talking about measles, we're really thinking about, we're evaluating patients on 3 different categories. So just to briefly go over these categories for everyone's awareness. The first is, do people have clinical signs and symptoms? And so this includes a fever and a rash and one of the 3 C's, which otherwise known as cough, a runny nose, and or conjunctivitis. And this is what we're, providers who are working in EDs and urgent cares and in primary practices are looking for when they see their patients. We're also concerned about susceptibility. And what susceptibility means is, are people actually at risk for getting measles? So like I just mentioned, in the United States, all of our measles cases, 97% of those cases have been unvaccinated. So they are susceptible to getting measles. So when we think about susceptibility, we think about someone who has never gotten an MMR vaccine, someone who has never been exposed to measles, someone who is not born before 1957. People who were born before 1957, when we did not have the same public health interventions we do now, it's widely believed that measles was rampant across the entire United States, and that most people were exposed if they were born before 1957. And then we also consider people who have no documentation of previous infection. So if you meet those categories, you might be at risk for measles, but kind of really most concerned about the unvaccinated group. And then last, we consider exposure risk in the past 21 days. So measles can take up to 21 days from when you were first exposed to it to actually develop the signs and symptoms, which is a pretty long time period. I think a lot of us are used to, okay, I was exposed to COVID. I need to stay at home for, a couple of days, up to 10 days from when I was last exposed, especially early on in the pandemic. But for measles, that incubation period is much, much longer. And so we ask, did they have international travel in the past 21 days? Did they have domestic travel to an area that's known to have a measles outbreak? Or do they know that they were exposed to measles within their community or within their close contacts, family members, or within their household. So these are kind of the three categories that we're concerned about and that we're thinking of as we're assessing measles. You can go to the next slide.
Any questions on that? Comments, questions?
Lauren, do you know what the mortality rate was before people were immunized?
People who are immunized, so this actually goes right into part of my slide. So people who are immunized, the vaccine provides a 97% protection if they get both doses and a 93% protection if they receive one dose. If someone is immunized, I mean, I think I don't have the numbers right in front of me. I can look them up, but we're seeing pretty much no deaths in people that were immunized. And I think I simultaneously have our CDC data popped up. We have had 3 deaths in the United States, none of which have been in Colorado. And those were all in unvaccinated individuals. So I would have to look up the fatality rate in people that are vaccinated, but I would suspect that it is under 0.5%.
And my question was before there was immunization.
Oh,
What-
before there was immunization.
It's like
Let
1
me-
in 1,000. I think.
Yes.
I think it's 1 in 1,000.
I will say that with that, we want to not only think about mortality rate, we want to think about like lifelong morbidities. So people who do get measles can have lifelong consequences of getting that. So that can be common complications include ear infections, pneumonia, brain swelling, and in even rare cases, some types of late onset encephalitis that can leave people with lifelong impacts of a measles infection.
Great. Thank you. All right, I think we're ready to keep going.
I have one
Okay.
question.
Yeah.
Susan,
Wondered
one more.
how long a measles vaccine lasts and if people need boosters ever.
At this point, people who have received immunizations recently, as long as they get both of their MMRs on the recommended cycle and schedule, that is lifelong protection to measles. There are some situations in which individuals may have received a inactive measles vaccine, and that was in the years, I can look that up. Let me find it on our website. Individuals who may have received a measles vaccine from the years of let me find it. I can send out the link to this too. But individuals who may have received a vaccine in between 1957 or sorry, 1963 and 1967. And I'm going to put those years in the chat as well. 1963 and 1967 may want to talk to their healthcare provider about getting a measles booster because they likely received an inactive measles vaccine during their youth. If you were born in the mid 1960s.
Now, Lauren, just speaking personally, I could possibly be in that category, but I had the measles when I was 6 or 7 years old.
So then if you've had the measles, then you are considered immune and not at risk for getting it in the future.
Got it. Thanks.
No problem.
I have a question about the timing of the first couple of doses and of vaccines for young kids. And it's my understanding that in scenarios where we're dealing with an outbreak, it's the recommendations move down to as early as 6 months, and then you can do your in that case, you're going to need 3 vaccines, and it would be 6 months, 1 year, and then 30 days after that, or 28 days after that. But I haven't really seen that communicated to the community, and a lot of my fellow daycare parents are unaware. And it strikes me that this is the time now where we should be communicating that, because once we have cases in the community, those very young kids are incredibly vulnerable to this. And not only vulnerable themselves, but they're also going to be the biggest vectors of this in the community.
I really appreciate you bringing that point up. And so you are right. In when we are seeing commercial or community spread of measles, we can change our recommendations for people to get vaccinated sooner. Those recommendations have actually been made by the state of Texas that is seeing a large scale community spread, as well as the state of Kansas. Colorado is currently evaluating whether we are going to make those similar recommendations. We have not at this point, but if we do decide to make that recommendation as a state, it's not something we take lightly. It also impacts people's insurance and billing, and there's a lot of back end billing and insurance policies that go into effect as well that we have to make sure will be followed through and will be implemented. And so we are evaluating if we're going to make those similar recommendations and when we will. If we do make those changes in immunization recommendations to recommend people to get vaccinated at younger, starting at 6 months, that will be communicated in a statewide press release from CDPHE and a corresponding HAN, which is a health alert network that will be sent out to providers. And so we are currently evaluating whether we're going to make that recommendation as a state.
Thank you.
No problem.
All right, thank you. Other questions, thoughts? Okay, let's keep going.
Okay, and so obviously the first line of defense is getting immunized before, so receiving vaccine before being exposed to measles. That is going to be our best protection against disease here in Colorado. But there are circumstances in which people are exposed. They do not have any immunity to measles, so they've never been vaccinated. They have never been exposed to measles or had a previous infection, and so they are at risk. In those situations where people are at risk, we have 2 things in our toolkit. We have what we call is post-exposure prophylaxis. So this is for someone who has been exposed and would like to seek care so they don't develop severe disease. Our first in our post-exposure toolkit is receiving an MMR vaccine after they've been exposed. The administration of vaccine to contacts who don't have any immunity to measles may abort infection or modify disease if it's given within 72 hours of their first exposure. 72 hours, very quick turnaround time. However, a lot of providers across the state and in our communities do carry MMR vaccine on hand to routinely give it to children as part of their regular immunization. So we do have that in our toolkit. The second thing that we have in our toolkit is called IG, which is an antibody that can be given within 6 days of first exposure to prevent or modify infection. I want to note that for most people, giving that MMR vaccine is preferable to IG, but we do have IG as another tool in our belt if we see a large scale exposure, especially in unvaccinated populations. The state of Colorado, so CDPHE, maintains a stock of IG. It's typically not on hand for most providers, and we can make it available at the request of LPHAs, so at the request of Pitkin County, and we can distribute it to community partners. So we could distribute it to hospitals or other community care centers within Pitkin County if there was an exposure. but all of that ordering has to go through the state of Colorado. This is the big, I have this in asterisks here. People who have been exposed to measles who do not have any immunity, so they've never been vaccinated, they've never been exposed, and they're unable to receive or refuse to get post-exposure prophylaxis. I say required, but I'll say recommended, required, quarantine for 21 days from their last exposure, if that takes place. So people who aren't vaccinated, I'm going to say that again just so it sinks in. People who are not vaccinated or don't have any previous infection to measles, if they do not get post-exposure treatment, they will have to remain at home, isolate for 21 days from their last exposure. And I'm going to pause and see if there's any questions.
Not seeing any, thank you.
Okay. Next slide.
Actually, I do have a question.
Oh.
Lauren.
Oh,
Liz
go
has
ahead.
a question.
Do you know if Texas has been using those post-exposure prophylaxis a lot?
They have. They have. I want to note that the Texas outbreak that we're seeing a lot of was in an unvaccinated, largely unvaccinated population. And that is why we're seeing so many cases come out of Texas. There are pockets of unvaccinated groups in Colorado as well. And so Texas has been doing the best they can to do community clinics and offer that for their constituents, but because of the large number of cases they have so far, it is really a lot of community spread, and unfortunately people are being exposed and not aware of it, and so they might be out of the window that are eligible to receive those interventions.
If an infant that's younger than 6 months is exposed, are those modes of prophylaxis available to them?
It depends on the situation. It depends on their immunity status. We'd have to work with that individual provider to see if that child would be eligible to receive any post-exposure. A lot of times they might not be, and so we would have to work with that on a case-by-case basis.
A quick question just regarding Mexico's mentioned here. Are we tracking measles outbreaks in neighboring countries?
We are. I do want to note that Mexico is having a large outbreak, an unprecedented outbreak. Same with Canada. Data for countries outside of the United States has been limited. And so we have not been getting, Canada is doing a great job of updating their dashboard. Mexico, not as much. And then there's also several countries across the world where measles is endemic, and they are constantly having measles outbreaks. So Mexico and Canada for sure right now are seeing unprecedented levels, just like the United States.
Great, thank you.
And so I want to talk through our 3 cases that we have had here in Colorado. You will note that the language I'm using is we have 3 cases. At this point, we are not counting the cases that we have in Colorado as an outbreak because they are not linked to each other. So right now we have 3 cases, individual cases in Colorado, but we are currently not in a statewide outbreak because these cases are not linked together. So the first case was we put out our first press release on March 31st. It was a case identified in a Pueblo resident who recently traveled to an area of Mexico that was experiencing an ongoing measles outbreak. Unfortunately, this was reported to the state late, and we were outside of that post-exposure treatment window. And so although we did reach out and put a press release to the community and reached out to that individual's contacts, we weren't able to give post-exposure treatment to most of those people. And we did ask that they monitor themselves for 21 days after exposure if they were immune and they were vaccinated, which all of them were in this case that we were aware of, and that we advise them to avoid public gatherings or high-risk settings until after those 21 days. We just got outside of that 21 days of monitoring, and we did not have any additional secondary cases related to this in Pueblo. Okay. Next slide.
Are we doing okay on schedule for you?
We're doing good for me. We'll have plenty of time for more questions too. So if you guys have anything, let me know.
Sure, go ahead.
So our second case, we sent out our press release on April 7th. And this was in an unvaccinated Denver County resident who was under 1 year old. This infant had recently also traveled to Mexico, which was experiencing an ongoing measles outbreak. And we were able to do some contact tracing. The only community exposure that this person had was presenting to the Denver Health Emergency Department. And so we worked with Denver Health to get a line list of everyone who was exposed to that case, or hopefully everyone that was exposed to that case. We evaluated over 120 contacts, including people who were in the waiting room, healthcare providers, nurses, sanitation staff that worked at the hospital. And so we evaluated over 120 people. We were able to give MMR vaccine in a timely manner to some of those contacts, and PEP IG to some of those contacts. There was a couple that were outside of that range that we advised to quarantine, and are continuing to monitor. Denver Public Health is continuing to monitor those individuals until they're outside of that period. This we are still evaluating those contacts. We're still have 10 more days of evaluating those individuals for related to this case. But no secondary cases at this point. Okay, next slide. Our last case, and this is probably what is, especially in Pitkin County, on your guys' radar, is our most recent case in Archuleta County. We had a case of measles in an Archuleta County resident. This person's vaccination history was unknown, and current evidence showed that they were not linked to cases in Pueblo or Denver. This individual was at Wolf Creek Ski Resort all day while they were infectious on Friday, March 28th, 29th, and 30th. This was Wolf Creek's closing weekend. And so there was a lot of staff and visitors that were at Wolf Creek that could have been exposed. We have evaluated over 400 contacts to that case. We have called over 400 people. We were able to receive a line list from Wolf Creek of all of their staff, everyone in their ski school, and anyone else that was on a large trip that was hosted by Wolf Creek. I want to emphasize that there may have been other individuals that were exposed that we did not get a contact list for. However, we have issued local press releases across the entire region. We issued a nationwide call for cases with the CDC. We have put out our own press releases, and Wolf Creek has tried to send out information to all of their pass holders about this potential exposure. We were also outside of the window to get post-exposure treatment for most of these individuals. So a lot of this was education and contacting all of the contacts to understand what their immunity status was and if they were a risk for developing measles. Out of the over 400 individuals that we evaluated, 3 are currently being monitored daily for because they were unvaccinated, and that we're monitoring to make sure they do not develop symptoms.
A quick question. I was just wondering if you explain what unknown vaccination status means as far as what you guys tried versus how unknown it actually is.
Yeah, that's a great question. So here in Colorado, we have our Colorado Immunization Information System, otherwise known as SIT. And this is our statewide database to keep track of all immunizations that happen or occur in the state of Colorado. So we are able to look up anyone's records by their name and date of birth to see if they've ever been vaccinated in the state of Colorado. And so we're looking those up for all 400 people, but there are several people that we do not have vaccine records for, or we weren't able to get a hold of them on the phone and confirm their vaccination status. So a good example of that is myself. I did not grow up in the state of Colorado. I did not receive my MMR vaccines in Colorado. And so it does not exist in CIS. However, if someone was able to get a hold of me, I would be able to confirm my vaccination status and also send my, records over to confirm I've been vaccinated. So there are some individuals we were not able to get on the phone and did not have records in CIS, and therefore we kind of classified them as, and that's how CDC is doing it too, is an unknown vaccination status.
So like this individual, case 3, you can get them on the phone. You never were able to speak to them?
With, without disclosing too much information about this individual case, we did get them on the phone, but we were not able to get a vaccine record for that individual.
Okay. Thank you.
No problem. I guess I can say that they were not vaccinated in Colorado with MMR, and they weren't able to get their vaccine record from when they were a kid.
Okay, thanks.
So that was
Lauren, this
a
is
lot.
Kurt.
Yeah.
Hey, I had a question. I was just on the statewide measles call right before this meeting, and I heard there were some updates to this case. I don't know if you had those in your notes at all about the 2 additional cases outside of the state that are associated with this.
Yes.
I don't know if you want to speak to that a little bit, because it sounds like the CDC may be listing that as an outbreak because of EpiLinks with this case.
Thank you, Kurt. Yes, I was going to mention that. So we haven't. This is a late breaker, and it's not included in our notes today. But we have identified a couple of other cases that are linked to Wolf Creek. We do not, because of the way that timelines lined up, we don't think that they actually got measles from our case, but there were individuals in other states that have contracted measles and did have exposures at Wolf Creek prior to our case. And so we are currently working with those states to gather more information on timelines. So we do have 3 cases linked in Wolf Creek right now. We have not released a press release on this yet, to my knowledge, but I've also been at a training all day, so I could be a little behind. We do have 3 cases linked to Wolf Creek at this point. And so it's only 1 Colorado resident and then 2 other cases that are in their home states. We are planning on doing some more increased vaccinations in Pagosa Springs and in the region, and are bringing our mobile vaccine buses out there to provide that to the community.
Thanks, Lauren. And I would just add that on this state call that we haven't seen secondary transmission or any evidence of that from these cases yet, even with the additional 2 cases. So yeah, just to...
Yes, that is correct. And we have not, again, thank you for saying that. We have not seen any secondary cases, but we're continuing to monitor a couple of individuals.
Other questions? Don't see any. Let's keep going.
Okay. So this is, again, my table that we talked through earlier, clinical compatibility, susceptibility, and exposure risk. We are getting calls, tons of calls every day to do measles rollouts. We are asking providers to give us a call whenever they think someone is presenting with measles at their clinics and evaluating them by these 3 categories. If you want to go to the next slide. Based on those 3 categories, again, clinically compatible illness, confirmed or likely exposure, if they're susceptible to measles, we are then classifying them into different risk categories. High risk if they meet all 3 criteria, moderate risk if they meet clinical compatibility and one of the others, and then low if they only meet 1 or fewer of those symptoms. And so with these are the recommendations we're giving to healthcare providers across the state when they call us, and then also helping them coordinate testing, whether that be at the CDPHE public health lab or through commercial laboratories for testing. And so I don't want to get into the too much nitty gritty on this, but CDPHE is available. Our phone numbers are on this slide here. Our general phone number, 303-692-2700. Providers can give us a call anytime during the day to evaluate and work with them on evaluations. And then also we have several staff members that are working at all hours of the night to do after hours consultations as well. And so we have our after hours number listed here. This is also listed widely on our websites, on all of our public health releases, press releases, and health alerts that are going out. And so we are widely available to take calls and assist. If we become aware of a case or someone we're evaluating that is a Pitkin County resident, Pitkin County Public Health would be notified. We're doing email notifications for low risk because we do not think that they have measles. But then for moderate and high, we're doing email notifications and getting someone on the phone from Pitkin County Public Health, even if that means after hours. We do have after-hour contacts for Pitkin County and would be contacting you guys directly, getting someone on the phone if we had even moderate or high suspicion of a measles case in your jurisdiction.
I have a quick question about this. Not understanding the different labs that are listed there. Do we have like a protocol to, as we sort of did with COVID, where people will be meeting people at the door instead of having people go into the hospitals here? If there is an instance where we're having a lot of people tested for measles?
So I will say that is our best practice, and that is what we're advising providers when we have them on the phone. If we, for whatever reason, get in contact with a case before, if they're calling us instead for whatever reason, or we're doing contact tracing on someone, we always advise the patient to not present at an emergency department or an urgent care clinic or just walk in. The state's policy is to make sure that that provider knows that a suspect case is coming in. But I will say that that is the ideal. That is not always the situation. And so I would recommend hospital IPs to have their own hospital IPs or even clinics to have their own policies on that. And we can work with them one-on-one too. We have infection prevention guidance listed on our website that's linked in my slides today. Also available to work with. I'm available to work with any providers or hospitals to talk through that as well.
And to add to that, and I'm sorry, I forgot your name.
Cecily.
Cecily,
Yeah.
thank you. So we have been meeting with Aspen Valley Hospital. We have a monthly meeting, and so we've been talking about measles. So they know that the outbreak is ongoing. We've sent out information to providers. What we expect is we're going to probably see people going to providers to do that, and then how they can handle that. And then if they are sending something on to AVH, to call first so that we can try to isolate those. I think, to the best of our ability, we can do that. I think the random case that walks in will be the challenge there. But
Yeah.
they've got protocols in place and they're already aware of the outbreak going on in Texas and the protocols that they would need to follow to try to isolate that as best they can. So, yeah.
Other questions?
Any other questions?
Looks pretty good. Let's keep going. We've got about 6 minutes left.
Okay, so this is really just talking through what measles reporting looks like in the state of Colorado. Even suspected measles cases are reportable in Colorado by our Colorado code and regulations and state statutes. So we ask that providers either immediately contact their local public health department or CDPHE directly to report a suspected case and arrange testing. Again, our phone numbers are listed. We do not want providers to wait for test results. We want all suspect cases, especially if they're moderate or high, to go directly to CDPHE's public health lab in Denver instead of them going to other commercial labs like LabCorp, ARUP, or Mayo Clinic, to name a few. We want them to come to our lab in particular because we have much faster turnaround times and can prioritize specimens. We can order stat couriers if needed. We can get turnaround times in 24 hours. And so that is why we're asking you guys to report them directly to public health. This messaging has gone out to providers. It has been in all of our press releases. It has been in all of our health alert networks. But I do encourage any of you on the call today that do work routinely with hospitals or clinics to reiterate this to them in any conversations you're having. And then we are asking, if it's a suspect case, to collect an NP or OP swab, for our clinicians on the call to do PCR testing. And we do have guidance on that. We, in some cases, would ask them to obtain serum for antibody testing if that's a concern. But I really just want to reiterate, you should be notifying public health. You should be calling us on a case-by-case situation. We will coordinate and evaluate that with you as those come up. So any questions about measles reporting?
Don't see any here.
Okay. Our last slide today, and I want to just touch on this, is that this is our MMR vaccination rates for the state of Colorado. There are some counties that do have lower vaccination rates, and you can dive into this data in Pitkin County. I know Pitkin County Public Health already has to talk about even immunization rates that are drilled down to the school level or the district level. And this is publicly available on CDPHE's website for you guys to look at and reference after this call today. I want to note that we publish this only once a year. So this is immunization rates for the 2023 to 2024 year. But I do know that we're seeing an uptick in MMR vaccines across the entire state. So I do believe that this would likely be an underreporting of the immunization data in Pitkin County, but just want to reference those years that this is from last year, and we'll be updating our tables in the coming months with this school year's data. Okay, last slide is my contact information. So I know that Pitkin County Public Health staff already has it. Pitkin County is just such a great resource, and you guys are the best locally, but want to make sure that you guys have my contact information. That's my direct cell, my email, and then also all of our subject matter experts here at CDPHE that are doing the heavy lifting, our vaccine preventable diseases team, our immunization branch, our communications team, and our lab coordinators. If you have any additional questions, I'm always available. I know we're just at time, so please do not be afraid to reach out to me directly for follow-up after this today.
Great. Thank you, Lauren. This was really fascinating and thorough, and appreciate you spending the time with us. Any other last minute comments, questions, other than thanks? I think we're all very satisfied here.
Yeah, thank you.
No problem.
Yeah, have a great afternoon and hopefully we'll see you again sometime, but only when we really want to see you rather than if we have to.
Agreed. Thank you guys. I'm gonna hop off this call, but again, you'll have my contact information and slides after today, and hope you have a good rest of your day.
You too. Take care.
Thank you.
Thanks, Lauren.
Okay, now the moment we've been waiting for is our next VIP guest zooming in is Jordana. Take it away.
All right. First of all, sorry I can't be there in person, but recovering from a broken leg. So thank you for letting me join remotely today. I first did just want to extend a welcome to Cecily and Sam. Glad to have you on the board. And I'll be reaching out so that we can have some time to connect and get oriented for all of our new board members. I do a little bit of an orientation and provide you some information. So when I'm a little bit more mobile, we can get that scheduled. Today, I just have this one slide and just some updates of what has been going on the financial side of around our department lately. So the first update is around the Healthy Community Fund. So as many of you know, the Healthy Community Fund is a tax, a local Pitkin County tax that supports the public health department itself. Some of our general operating funds come from that tax, as well as it supports senior services, and then a number of different nonprofits throughout the valley providing health and human services. And so this the current Healthy Community Fund tax is set to expire in 2027. The Board of County Commissioners had some discussions during their retreat this winter and gave us the direction that they'd like us to be able to put that renewal or to put the Healthy Community Fund back on the ballot in 2026. So that will be in the fall of 2026 and gives us some time to plan for any updates that we would like to see to that tax, or if it's just a straight renewal. Either way, just again flagging that this will be a great opportunity for Board of Health members to help promote the work of the Healthy Community Fund and hopefully help get what gets on the ballot approved in 2026. Any questions there? If not,
Go ahead.
we'll go forward with the latest of yo-yoing around federal funds that has been experienced. So just to let everyone know, we had a stop work order issued for the COVID-related federal grants that we receive. And this was in March 27th of this year. The grants themselves are expected to expire at the end of June. But if they were ended early, there could be up to $30,000 of funds that we would not be able to receive. Because the BOCC is actually who oversees our budget. We went to them with this issue and they had agreed that our fund balance could be used to cover the difference. In the meantime, on April 1st, 23 state attorney generals, including our own states, filed a lawsuit in response to that recent federal public health funding clawback. And on April 3rd, a federal judge issued a temporary restraining order that said basically you can't restrict and claw back this funding until April 16th. Currently, today, there's a temporary injunction on funding cuts being heard in a Rhode Island court. So I will provide you the updates of that via email because we don't yet know what the response or what the outcome of that will be. so that's a little bit of how we are experiencing some of these federal stop work orders, where they're stopping, then they're starting again, and then we're kind of waiting to see what is coming next. So any more questions on that particular funding source?
Questions, thoughts, comments? No, it doesn't seem like it. We're gonna wait and see what happens.
And that is it for the update I wanted to share today.
Great, thanks, Jordana. That was easy. We're gonna go right into round robin where board members have an opportunity to bring up topics of relevance and interest to the board or to the public health, Board of Public Health. Anybody have anything they want to share? Dr. Kurt brought up op-eds earlier, and I'm just wondering, what's our status on op-eds? Do we have anything in the hopper?
Let me pull up what the next one is. Just give me a minute there.
Were the op-eds like general public health announcements, or were they
Op-eds
specific?
by board members.
Jordana.
Yeah,
Oh,
so,
understood,
and if
okay.
you're interested in doing one,
Oh,
that's
gosh.
good to know that we'll
Okay.
be soliciting topics
Then-
and writers.
Oh, I didn't.
The next volunteer we have is Susan to write an op-ed on rabies in July.
Well, that'll be fun.
Compelling. That's gonna be a good one.
Rabies.
Oh, rabies. Well, what number do we call?
I don't know.
The rabies number or Susan?
Yeah, my cell phone.
Call Susan. Yeah, if you get rabies.
Yeah, I might need some help for them.
Absolutely. We will provide as much support as you need in getting that message out to the community. But that's a great topic because we found that last year the community is aware of rabies and that if they find a bat in their bedroom or a dead bat, that they should do something with it. They just don't know what to do with it. So we had folks showing up in all different kinds of places with bats, sometimes dead, sometimes alive in a Tupperware. So we really want to make sure that we get that message across of what to do and where to go.
Okay, great.
Good to know.
And that's for July?
Mhm.
Okay.
Yeah, so
Yeah, other op-eds, Jordana, if you've probably been thinking about op-eds that might be relevant.
yeah, the other ones that we've got on tap are Linda with respiratory illness in September and really focusing in on, what influences people to choose to vaccinate or those that are vaccine hesitant and how to help bridge that gap. And then Dr. Tom Kurt was interested also in talking about writing a column on respiratory illness and the kind of ins and outs of vaccines, where to get them, where to go, when to get them, and those kind of details.
Great. Thank
I'm
you.
also interested in the topic of alcohol, which has been of interest recently because women are drinking more alcohol nowadays. So with the summer coming up and food and wine, I don't want to say anything contrary necessarily. but I
Sorry,
think-
was that directed to me?
I think there are alternatives such as mocktails and non-alcoholic beers that can be sort of discussed.
That actually would be, seems kind of relevant because I have seen mocktails popping up on menus everywhere.
There are
And
menus.
I can attest that the quality of non-alcoholic beers has gone, somehow they've hit like a milestone and they're actually drinkable now after decades of them being so bad.
And wine.
And wine as well. I
Yeah.
haven't found a wine yet that was,
Oh, I
that I,
have really bad non-alcoholic.
The
Yeah.
ones out of Germany are like nearly,
They're
nearly
getting-
drinkable.
Oh, wow,
Yep.
nearly drinkable. That's like the
Yeah.
best recommendation. I've
Yep.
had. Yeah. I discovered that, yeah, I discovered that, I think Stella has a non-alcoholic and there's another light lager, Guinness makes a really good non-alcoholic stout. And that to me is like perfect. So, so Jordan, I brought this up last summer or last fall, and I wanted to ask Lauren so badly today about their data on, and maybe this has already gone away and I just didn't hear it or don't remember, but data on ER visits for bicycle injuries that did not involve automobiles. And it seemed like our county in particular was multiples of other surrounding counties, even places like Fruita and, Mesa County had lowered multiples. And I don't know if that was an aberration, but with mountain bike season approaching, music festival students arriving, has it reached a level where perhaps we should write an op-ed about helmets or something?
Good point.
E-bikes,
E-bikes and,
speeds.
tourists who haven't ridden a bicycle at elevation ever or lately. Yeah.
Yeah.
Just wondering if that falls into our purview.
Yeah, I mean, I think if there's interest among a Board of Health member to write an op-ed around those lines, safety and the importance of helmets and reducing TBIs, traumatic brain injuries, is something that we could help pull data from. We tried to reach out, or we did reach out to the state, but never quite could get to the bottom of that anomaly of why that rate was so high. And we couldn't quite get a great answer on the source for data that they were using when they were saying residents, whether those were full-time year-round residents or anyone who just noted Pitkin County as their residents. So if they were kind of counting some of our seasonal residents in that figure, while only using census full-time year-round residents in the denominator, which would inflate it seemingly. So unclear, Greg, we weren't able to get a definitive answer of whether that rate was astronomical or if it was a data anomaly there. But the topic, if it's something that a board member would like to explore, we could definitely provide information there.
Great, thank you. So the numerator would be the number of people that happen to be in the community that were in an accident. The denominator is just the residents, like the permanent residents of the county or the city, something like that. So it could be a factor of 3 or 4 times higher, depending on the time of the summer. Okay, I get it. Okay, just don't want to beat a dead horse there, but I was still wondering if we have something. It sounds more like an anomaly to me. I'll just call it that until you change it. Liz.
I thought I'd heard recently, maybe the city of Aspen, or I don't know if it's Public Safety Council, or who is doing more of an education campaign this year about e-bikes. So
Right.
I think there's something building already that maybe we could tag on to.
Right.
Or
Right.
not duplicate it, of course. But
And as we're trying to use more bicycles, we-cycles and the like for commuters and getting people around town instead of cars, the opportunities, we just might have more frequency. Not every community our size has we-cycle. I don't want to point my finger at we-cycle because they're such a great resource, but it's something to think about, and maybe a helmet op-ed is good regardless of what we see for incidents. Any other round robin comments, questions, thoughts on topics?
I have and I don't know, given I'm brand new to this board, so I don't know how much you guys have tackled this, but I've had a concern about swimming for kids in the county. And it's one that's just echoed so strongly by so many parents, and that there's just limited options for really young kids. And there's programs, and I think this has been tragically seen in, I think, one young kid in Basalt and then one young kid here last fall. And that we're not enabling our younger children to learn how to, most importantly, get themselves onto their backs really quickly when they're in a situation in the water that's unsafe. And there's been many, many, many requests by parents to our local rec centers, both the Aspen Rec Center and the Snowmass. And I know there's also been even requests to some of the private clubs like the the Maroon Creek Club and the Snowmass Club to do programs that resemble more of like an infant self-rescue program. And that has been like overwhelmingly denied, even though many moms and dads have asked for it. And I actually was with Alyssa, the mayor of Snowmass, and she showed me a video of her. And I've seen this with kids that come here for the summer who have had the opportunities in bigger cities. She showed me a video of like her 2-year-old niece kind of plopping into the water, barely knows how to swim, but immediately rolls to her back. And so she's had this like incredible training, which is now becoming more and more ubiquitously offered across the country, to learn how to basically just do your like basic life-saving thing, which is like get to your back, get to the edge of the pool, just really simple things. And it's something that has been, and I think there's a lot of reasons behind this. It's a bit of an ideology thing between the Red Cross system and the infant self-rescue. But I almost wish that we could take those two like brands out of it and just look at how much are we teaching kids like the most important thing, which is like getting to your back in like a moment of emergency. And it when I've had just so many parents come to me and be like, we've thought about going to Denver for 5 weeks to do it. Like, what can we do? How can we rally behind this? We actually have an ISR teacher here locally who's been denied by every single pool as she's tried to teach in them. But it's just something that comes to mind as like a really important thing that we could tackle and we could improve. And it's also, to my knowledge, one of the only causes of death that we've had in children in that age group in the last like 4 or 5 years. So I just wanted to bring that up, that it's been something brought to my attention many times by many parents. And I've had a similar experience. And there's some great swim teachers in this valley, but they're not necessarily geared towards getting the kids that are of the most vulnerable age in a position to rescue themselves if they're in an emergency.
Do you know why she was denied at the pool?
Because they don't, they're worried about losing, it's an insurance issue, it's an ideology issue, it's new. It's something, and then a lot of pools worry that they're going to lose their Red Cross certification if they allow for ISR. Again, I don't even know that we have to have like ISR per se, but it is like I have now had people from all over the country like tell me about these really positive experiences with ISR. And I think it's gotten a bad rep for being like, you throw the baby in the pool and they,
Yep.
you know, it's like, but now that I've talked to so many parents who are like overwhelmed with the experience from it, and they feel so much safer, their kids are so much safer. I really believe that offering people in Pitkin County the opportunity, you don't have to be forced into it, but we're basically getting shut out from being able to do it because of kind of I feel like it's a battle of the brands. Like it's, it's, yeah, one versus the other. And really it should be both. Like they both provide really valuable things, that they can bring to the table.
Great, thank you, Cecily. So Jordana, how would we respond, move forward on that? Do you need direction from our board if some board members thought it was worth pursuing to direct staff, or is it something you could just look into, or is it too far afield, or what do you? I don't know how to
Yeah.
respond, Cecily.
You know, I think what public health could provide, is the evidence base, for where we're seeing in mortality in young children of that age gap. And, could do some literature review if there was anything out there on ISR to help provide and make the case. I think what I'm hearing Cecily say is, then that might be what we were able to provide, and then bring that back to board members who might be able to help facilitate. It sounds like it might be more of an issue of trying to dig into whether the ARC and the Snowmass Rec Center, what those issues would be, and being able to allow that to be taught and presented.
Yeah, and I think that would be actually a really great place to go. And I think that I've spoken to both directors of those pools, and I think that there's like multiple levels of like sort of in some cases it's ideological, in some cases it's kind of red tape, like of like the ISR, ISR or any type of technique where you're trying to teach a really young kid how to get on their back has to be done nearly every day, but for a quick period of time. So it's also logistical. So, and I think like, I know that Allie up at the Snowmass Rec Center is open to it. But we would have to really like facilitate evidence, a community desire, and like community support for her to be able to really bring that into the Snowmass Rec Center, because it's a heavy lift. But it's one I've just heard from so many parents that I think it's worth exploring.
I'd propose that you get together with Jordana or designated staff and try to figure
Yeah.
out a way forward.
Totally. That's great.
Does that sound like a good idea? Heads nodding. Okay, thank you for that. Anything else, Jordana, on that topic?
Nope,
If
that sounds
Cecily,
good.
you're going to be giving Cecily the secret handshake and all that anyway, so you'll have to get together.
A giant notebook, yes.
Right. It's more like a secret handshake and an amulet, right? Anything else? I think we can close out round robin if no one else wants to say anything. And our next meeting date is July 17th. I expect to be here. Hope you all are too. And other than that, do I need a motion to adjourn? I can never remember. I do. I need. Did you say so moved?
Yes.
I'll second.
And we have a second from Susan and a third from Linda. All in favor? All right. Thank you all for attending today. You made it so easy on me. And it was fascinating hearing from Lauren and Jordana. We expect to see you walking around without any signs of limp in July.
Try my hardest.
Yep. All right. Good. Thank you all. Take care. We can shut it down.
Oh,